Ulrika Elmroth will present herself a bit more, but she runs the project on a national level. And how many heard Anders Vege's name yesterday? What matters to you? Maureen elevated and praised Anders in a fantastic way. And he's become a good friend. And you will also present yourself a bit more. So we will talk about 2 quality improvement initiatives on a national level, as Göran said, one in Sweden and one in Norway. And when we are discussing quality improvement, we normally need data. And when we collect data, people sometimes become a bit nervous. They think it might be used for something else than we say. So let us be very clear. These are 2 quality improvement projects, initiatives, and we collect data not for control, but for improvement, for quality improvement, to having a dialogue and educate each other and follow your own results. Ulrika will give us a national view on the Swedish project, and afterwards I will go back and look at how we follow our own results on a micro level. So thank you, Ulrika.
Thank you. Yes. Hi, everybody. I'm Ulrika Elmroth. I'm a general practitioner working in Sweden. And for the last 3 years, I've had the privilege to be the project manager of Primary Care Quality Sweden that I will spend a few minutes telling you about. I work at the SALR, the Swedish Association for Local Authorities and Regions. Do any of you work in primary care? Yeah, quite a few. I don't know what it's like for you, but to me, when I'm at my health center, it can sometimes feel like this, that it really has the potential to be the best job in the world. But sometimes the circumstances and conditions aren't allowing us to work the way we would want to. And I often show this picture to my colleagues, and they all recognize this picture, that it's a heavy job, and sometimes you don't have the opportunity to take a step back and think about what you're actually doing. So over the last few years, it's become very clear that we need a shift in the Swedish health system. Now it's very heavy on the hospital side and very specialized, and we need this strong primary care to be a better base in our healthcare system for it to work in a more efficient way. And that brings us to this guy. Anyone recognize him? Yeah, a lot of you do. So happy to hear. It's Zlatan Ibrahimovic. It's probably one of the most famous Swedes right now. And he's pretty good at what he's doing, right? Yeah, hard to disagree. But he's been practicing a lot to become as good as he is. But did you know that we have lots of Zlatans working in Swedish primary care? That's a pretty well-kept secret. Not a lot of people know about it, but they do. And they perform small and large miracles with their patients every day. But how do we know? Well, sometimes, we can get hugs from our patients or, or things like that. But wouldn't it be nice to be able to show both to your colleagues, to yourself, and to others, stakeholders, what a good job we're doing in primary care? And also, now, when we want this shift, we need more doctors, nurses, and other professions to work in primary care. And then, if they feel like this is a place where you can really make an impact and make a big difference for people, this is the place where I want to work. So, at the SALR, we wanted to make something to support primary care. And we have this concept called quality management. And it's based on 4 building blocks. If we begin with the knowledge, we need the best available knowledge in order to treat the patients in the best way. Sometimes it's evidence-based medicine, but in lack of evidence, we have to have some other knowledge. And then we need data to evaluate, do the patients really get the care they're supposed to get? And nobody gets healthier or happier with just looking at data. We need to do something with it. And then we need the improvement skills and the know-how and the methods. And of course, central to all this is the leadership. So now we have a package to Swedish primary care with support in all these 4 building blocks. And we hope that this will be one way of helping Swedish primary care to give good care to the patients. So what is primary care really? It's Primary Care Quality Sweden. It's a quality improvement system. It contains about 100 quality indicators and also the technical solutions for collecting data automatically and then presenting it both at the local and the national level. And this originated in the professional organizations. It came from the primary care professions who invented this and who still are actively working with the indicators. And it's doctors, nurses, physiotherapists, occupational therapists, psychologists working together. They're all clinically active in primary care. And that's also one success factor, because we all know that the magic happens in the microsystem, right? In the meeting with the patient. And for professions to be able to use this and feel confident and trust it, they need to know that this is not some bureaucrat who invented to control us. This is my colleagues who invented this, and this is clinically relevant and good to use. So we need also some investments in technology and other infrastructure around it. So in 2015, this collaboration between the professional organizations and the SALAR and the regions started.
Och så går jag in på huvudmenyn och så rapporter, och då har jag primärvårdskvalitet här. Och vips så har jag alla de här nationella indikatorerna framför mig. Och om jag tittar här då till exempel på förmaksflimmer.
She works at a health center in Stureby, south of Stockholm. And just for a minute or so, she will show you how this works in reality. And she speaks Swedish, so I'll try to translate it to you. Let's have a look.
Och så går jag in på huvudmenyn och så rapporter, och då har jag primärvårdskvalitet här. Och vips så har jag alla de här nationella indikatorerna framför mig. Och om jag tittar här då till exempel på förmaksflimmer, så bara håller jag musen över hela stapeln. Och då får jag på vad det är vi skriver. Det här är då prevalensen av patienter med diagnosen förmaksflimmer. Och här kan jag se hur stor andel av patienter med förmaksflimmer som har antikoagulantbehandling. Det här är intressant, och då ser vi nu att här är vi en bit över medel. Ja, och så klickar jag på den. Och då kommer jag in i det. Och då kan jag fortsätta se här hur många patienter med förmaksflimmer som har antikoagulantbehandling. Och för oss är det 160 av 192. Jag kan jämföra, här är vi, gula stapeln, Stureby vårdcentral. Jag kan jämföra med övriga landet och vi ligger bra till. Och här kan jag också se jämfört över tid hur utvecklingen har sett ut. Men om jag klickar här då på våra patienter, då får jag staplarna här idag. Här ser jag vilka, den blå delen här, vilka som har antikoagulantia och vilka som inte har det. 32 personer har vi, 32 patienter som inte har antikoagulantia. Och det är det som är det roliga, för nu klickar jag bara på det här. Här får jag patientlistan. Och då står det vilken läkare de träffar och till och med också att man får en Schadsvask-scoring här. Den är bara att dela ut till ansvarig läkare. Och så kan man då direkt jobba utifrån det.
They can save a few lives actually at her health center just through using this. But of course, we always have to make an individual assessment because clinical guidelines aren't for 100% of the patients, of course. So in brief, primary care quality, it's a quality improvement system that's adapted to the primary care setting. It's easy to use, and we use automatic data collection. We don't have time in primary care to fill in forms and different forms for different diseases and all that. So we need to use data that already exists and that we can pick up automatically. And luckily, in our electronic medical records, there's plenty of data already that's stored and just waiting to be used. And then we get real-time data on our own patients. And now maybe some of you is wondering, is it really real-time like in the stock market? Is it like NASDAQ? It's updated every few seconds? Well, maybe not really that often. But you know what it's like when you work with the medical records. Sometimes there's some delay with writing the records, and sometimes the lab results and measures come in a few days later. But as good as real time at least, and it's certainly good enough for improvement work. And as you know, when we measure things, we put focus on the things that are measured. And we also steal focus from the things that are not measured. And certainly, there are a lot of important things done in primary care that we can't measure. So we wanted to be very sure that we measure good things when we bring so much focus on them. So we want all our indicators to be evidence-based to as large extent as possible. And that means that we use the national guidelines that already exist in Sweden. And the indicators also, they are multi-professional, so different aspects of the care that we give to patients at the health center and other primary care can be shown. And of course, when there are new guidelines and new evidence, of course, the indicators need to be updated. So, how far have we come? Well, we started almost exactly 2 years ago with the first pilot with a few health centers in Stockholm. And now, over 50% of the health centers in Sweden have primary care quality. This is also a nice map that shows you the 21 regions and counties in Sweden, and they are all independent authorities responsible for providing health care to their population. And they had some different maturity when it comes to technology and using data from primary care. So for some, it was really easy to get started, and for others, they still struggle. So for some, it's easy. For others, it's a struggle, but they are all working on it. So I think at the end of the year, this number will be a lot higher. And also a few words on the data flow. And this is pretty complicated, I'm sorry, but this is also one of the keys to success. So listen carefully, especially if you're going to try this at home. This is a typical Swedish health center, you see, with the patients. And here, we want to see individual data and find the individual patients at risk or who need a checkup or so, like you saw in the video. The problem is that in Sweden, and I'm pretty sure in many other countries, it's illegal to make a registry of the entire population, as it would be. So we can't collect individual data in the entire country. So we had to come up with a different solution. So now it works like this. The individual data stays at the health center. And at the national level, we collect aggregated data. For each health center, or for each region or county, we get a number, like a percentage or so for each indicator. And this is shown at the national common collection of quality data from healthcare. It's called Vården i siffror, or Health in Numbers. I'll show you the address at the end of our presentation so you can go and have a look at it on the internet. And there you can see data from different quality registries, from patient inquiries and other sources, and certainly even also from primary care quality. And then we're not done there. We also want to use the benchmarking function and to share our data with each other. So from this national level, data is sent back to the other health centers so they can compare themselves. So data goes in both directions. And in this way, we overcome some of the biggest legal obstacles that have been a big threshold for this project to be able to work at all. These are some of the areas that we are able to cover right now, and we're working on finding out even more aspects of primary care that are important. As you see, it's quite a lot. And primary care is a very vast area to work in. Patients have so many different diseases and ailments, and sometimes they have several diseases at the same time. And as you know, that's not always the best thing to follow the guidelines, the more complex problems the patients have. All this, what matters to you, and that you know all about. So if we begin in the middle, we have the diagnosis-specific indicators. We have the large disease areas, the cardiovascular diseases. We have diabetes, pulmonary problems, asthma, dementia, psychiatric disorders, and infections, not the least. And for all these, we can show different kinds of treatment, of course, both drugs, but it can also be like psychotherapy for depression or anxiety. We have a rehabilitation, and also, for example, lifestyle habits. That's always important with all of these chronic disease, not the least. But then to your left, we have also the more overall primary care specific indicators that have to do with continuity of care. That's one of the biggest problems in Swedish primary care compared to other countries, that our continuity is low. So it's an important measure for us to be able to follow and improve. Also comorbidity, like we talked about. And also prioritization. How do we know that we see the right patients? And when resources are scarce, we want to focus on the patients that need us the most, right? So we came up with some indicators for that too. A pharmaceutical treatment that can be drugs that are harmful if you combine them, and also drugs that can be addictive, like opioids and benzodiazepines. And we have a special section on elderly patients that can be extra sensitive, not at least when it comes to drugs. And like I've talked about, all this comes from the professions, but we also want to involve patients. And to the right, we are part of this international project called PROMISE, which has to do with collecting patient-reported data. And here is an opportunity to get very interesting information from the patients that are hard to find in structured data from the medical records. So it will be a very good complementary function to the ordinary data. So here are some examples of the indicators and how they work. Like you saw in the video, how large proportion and which of our patients with atrial fibrillation have treatment with anticoagulants, and more important, who don't. And which of our patients with specific chronic disease and who are smoking have not yet been offered smoking cessation aid. And that can be any of the lifestyle habits. We have smoking, we have alcohol, we have diet and physical exercise. And also with the prioritizations here, which of our patients with chronic disease, one or many, have not had a checkup in the last 18 months. Some examples, but like I said, we have over 100 indicators, so there's plenty to dig in. And to sum up, before I hand over to Robert, we want this to happen at the micro level, that data gets used to improve care for the patient. But we can't just throw data to the health centers and expect them to work all those miracles. We need to support them somehow. So what needs to be done? at the regional and the national level. I've listed a few things that need to be done, but of course there are others also. So at the regional level, they have to do these investments in technology for local data and the feedback and benchmarking mechanisms. We also need to arrange regional support to their health centers, so both when it comes to quality improvement methods and the leadership, and support those structures so they can continue working and not lose their energy. And also, not the least, arrange arenas for spreading ideas and experiences. And at the national level, of course, we have all the management and maintenance of the indicators. We have the website where all the quality data comes from different sources. And also, we have this technology for aggregating data and the benchmarking function that I showed you. And also important, when we look at data, and especially aggregated data coming from different regions with different systems, it's also important to validate the data to see, are these differences really real differences, or are there other confounding factors? And also interpret data and do the analysis work. So now I will hand over to Robert, who will tell you how they work in Uppsala.
Thank you so much, but please stay a second, because I like to take some, yeah. I'd like to take this opportunity to thank you personally in front of everyone for all the work you and Stina Gare are doing on a national level. We could not have done anything on a regional level if you hadn't done that. So one more. Thank you so much.
We're quite a few of us, yeah. Some of us are in the audience too.
How many of you saw this yesterday? Anne, how many of you have named your fixed person that we should embrace? I named mine after a Swedish king yesterday evening. And so I can talk to him now and say, yeah, you know. I think I want to show you this. I want to connect what we're doing now to this presentation. I think it's extremely important to think of your fixed mind and your growth mind when you're dealing with quality improvement. And I'm going to go back to our system with our 50 healthcare centers and try to figure out where are they fixed, where are they growing, and so on, and see how that. And I think that's important in this work. I'll go back. Before I'm going to start to show you a few examples where we struggle, I would like to tell you that in our healthcare system, we have 375,000 people. We do some pretty good work in some areas. We are good at antibiotic prescription for the right thing at the right time in the right amount. We're fairly good with diabetes care. But there are a few areas that we are finding out that we are struggling in, and we do that due to primary care quality system. When we look into our system, we have a bit of a different view than Ulrika showed you on the screen before. When we look at heart failure is a severe condition that's lifelong. And it's very important that we find the people that have heart failure and that we treat them. That's good for the system level. You're too many to ask how many people should have heart failure in our system. We have 375,000 people, and we know that about 2% should have heart failure. So when we look at these numbers on a meso level, we see that we have only found half of the patients that we have in our primary care system. They might be somewhere else, but it might be so that we don't know where they are and we don't treat them. And we find this extremely important. Sitting in the regional office, you cannot do much about that, more than seeing that. And that's what Ulrika showed you with the meso level. You have to support this work. But the work can only be done in the healthcare centers, out in the microsystems. So why don't we have a look together at one of the centers called Eriksberg. A very good friend of mine, Dr. Louise Hamark, she runs this place. And of course, I can show the numbers of her healthcare center. Because she likes to show how it's going, even when it's not going totally fine. And we do that to show you how we can work with these kind of numbers. She also has 1% prevalence. She has not found everyone that she should have found. Do you see that? So she has 10,000 patients, so she should have 200 people with heart failure in her register. And she has 100. She actually has 95. They start now to work very diligently together with the team to find the rest and put them in the system so we can follow them. Otherwise, the tool is not. But there is a thing she can work with. She has actually found 95 patients. And as Ulrika said, regular checkups, continuity is very, very important. So she can look at that. Do they come back? Have they had a checkup during the last 18 months? Digging down, clicking down into the system, she gets a view with diagrams like this. And out of the patients that had a diagnosis from 18 to 60 months ago, from 18 months to 5 years ago, 39 of those came back during the last 18 months. That's good. She doesn't have to look any more on that. But what she needs to look at is the 23 persons that got a diagnosis 18 to 60 months ago, but they haven't been back. Where are they? If they don't come back, she can't treat them. Her team can't treat them. So she gets a list of patients with the social security numbers, which is well covered in blue here. And on that list, she can click on every single patient. It's up to her and her team to prioritize this job. But she thinks it's very, very important to have these patients coming back and see them again. So they do that. And when they do that, they learn something. And this is my favorite thing. I love to learn, and it's so nice to see others learn as well. She learns that if they don't put the diagnosis in the EMR, she can't find them. So when she clicks as a patient, she can say, oh, she's been back here 2 months ago, but they haven't labeled it right. Good, so they can label it. Patients actually go to the hospital. Some of the severe cases, they do go to the hospital. They don't come back to primary care. And she sees that as well. But the interesting thing here is that she actually sees that sometimes they have fallen between the chairs and have no appointment and no one has seen them. So she can book them in. And you see how she used the system provided by Ulrika and Stina and the gang from the national level, supported by the meso level, our regional level, and she works out in the microsystem. And she works like this, together with her 50 healthcare bosses in the other healthcare centers, that something can happen. Very shortly, how she works as well. Ulrika mentioned atrial fibrillation, and you saw a view in another system on the video. The prevalence for atrial fibrillation, I don't have it in my head, but it's the same thing like with heart failure. You want to find them all, huh? But you can actually see which patients have a very high risk of getting a stroke, getting a blood clot in their heart that goes away up in their head. And there is a risk score called Chatsvask. And if you have a high risk score, you have up to 16% yearly risk to have a stroke. So it's very, very dangerous. So what she does is that she clicks one more time, and she has a look on the patients with the 2 highest risk scores on Chatsvask 4 and 5. And she finds it valuable to have a look at each individual patient of those. So that's the way she works. She drills down. She has 15 to 20 different opportunities, different areas to choose. But she chooses a few, because that's the way to improve her system. That was what I wanted to show you. And Anders Vege, what matters to you today? Thank you. Thank you.
In Norway, we are running a program to develop pathways for elderly and long-term conditions. And we try to, at the same time, introduce to our system the question, what matters to you? And in a system perspective, and for an individual, it's the same. It's about asking, it's about listening, and it's really about acting on what you have heard. And why do we do this? In November 2012, I'm not sure which date that counts for your country, but in Norway it's like in November 2012, a curve started raising. 5.5 million inhabitants, and in November 2012, there were 625,000 elderly above 67 years old. If we go to 2050, there will be 2 times elderly above 67. There will probably be 3 times elderly above 80. So if you ask why those pathways for elderly and long-term conditions, that's why. So we know that we're going to live longer. That's one of the reasons why the development is like it is. We know that we're going to live longer. Does it look like this? Or can we actually manage to move the bow so that we create better health longer in life? Which level do you have for care? When do you have to start the home care? When does this group of patients start using the hospitals more? We know that maybe 20% of the patients spend 80% of the resources. When do the level of care start? It's a huge difference between those 2 bows. And the cost for the society is completely different. When we first saw these figures in Norway, we got a coordination reform, and we called it more and more, not a coordination reform, but a reform to change direction of care. Every system is perfectly designed to give exactly the results it gives. You probably heard it before. It's Paul Batalden. So do we have the system that can take care of a double number of elderly above 67, 3 times as many above 80? Or do we actually have to search for a change of direction? So if you think like me, stay with me on the following issue. I'm a nurse. I spent my professional career working with elderly. That was what I wanted to do when I was a nurse in 1986. And I learned at school, and I learned very early in my career that this is a normal stair of service. When you get old and you get in contact with the service for the first time, some kind of home care, maybe a hospital admission, then it's the beginning of something. And you have to have in mind those double figures of elderly, 3 times as many. And I think we learned that every elderly is going to be followed up these stairs. It's about collecting more and more care because you get weaker, because you lose functioning levels, so there has to be something there to cover for you, to get in and comfort you and help you. And I have learned as a nurse to see the weakness of the patient and then go in and compensate that weakness. Do you know the feeling? So this is long-term care related service. It develops and you get more and more of it. And there is an alternative to slow down the climbing in this stair, and that is temporary service, rehabilitation, reablement. We learned from the Swedes about home rehabilitation, reablement, and it went to Denmark, and they invaded Norway with the initiatives of reablement. And it was very, very important for the change of direction in our care. Day care, transportation, activity of daily living, technology, and you know, all the temporary service. But what really struck me when Anders Grimsmo, professor in social medicine in Norway, used this picture for the first time, he said, maybe we could help patients going down the stairs instead. Maybe the ambition is not to help them slowly upwards in the stair, but actually downwards. And you're going to see one example now. And if you let her, I think you will fall in love for the next 5 minutes. And it's only a short love. But allow yourself, when you meet Tordis, listen and see what matters to Tordis. And take her with you.
Det lårhalsbruddet, det var det verste som kunne hende meg. Også i min alder. Så jeg måtte ha hjelp til å komme ut av sengen nå. Men det var mange ganger lang ventetid før hjelpen kom, for det er jo så mange som trenger hjelp, så jeg måtte jo finne meg i det. Jeg måtte jo stelle som et barn, faktisk, til å begynne med. Og jeg synes det å ta imot tjenester, være fullt avhengig av andre mennesker til enhver tid, sånn, det synes jeg var vanskelig å akseptere.
Jeg har jobbet som hjemmehjelp i mange år. Da gikk jeg til brukerne hadde liste som jeg utførte ting som sto når jeg skulle utføre.
Vær så god. Her skal du få kaffe, ja. Vær så god.
Takk skal du ha.
Nå har jeg begynt å jobbe som hjemmetrener, og målet var at hun skulle klare mest mulig i egen leilighet, og vi trente på blant annet å ta på seg strømper selv, og at hun greide å lage frokost og koke kaffe selv, og at hun turte også gå i gangen alene med rullator, mens jeg satt inne i leiligheten. Da følte hun seg trygg.
Så var det Annie kom inn i bildet. Og hun også gikk og trente med meg, og trente også inne. Jeg hadde øvelser som jeg trente inne, og som jeg også trener for meg selv da, flere ganger på dagen. Det har jo vært drømmen min, det å kunne komme dit til at jeg kunne greie meg sånn som jeg gjør. Og gå rundt omkring og ordne meg selv og i det hele tatt gjøre det jeg kan. Kose meg jo mer selvfølgelig når jeg kan være hjemme hos meg selv om blant mine egne ting. Det betyr mye for meg. Jeg synes jeg har kommet meg veldig fint. Og det er vel en 3 måneders tid. Og det synes jeg har vært et stort fremskritt for meg. Jeg er glad for at jeg er kommet hit som jeg er. Og håper ikke bare at jeg kan fortsette med det. Og om morgenen så synes jeg det går greit, for nå får jeg jo på meg strømper og kommer opp og nei, det går greit, det er nesten som det var i gamle dager. Og det er jeg veldig glad for. Det synes jeg er et stort fremskritt for meg i hvert fall. Jeg tenker på hvordan jeg var like efter operasjonen. Nå ordner jeg frokosten min selv. Og trakter kaffe, og det går som vanlig som jeg greide. Det er ikke godt som jeg greide før. Så jeg synes jeg har kommet. Det har tatt sin tid. Men ved hjelp av gode hjelpere da, så har jeg kommet dit igjen at jeg greier det selv. Det ser man hva man kan greie da, ved god hjelp og ved trening og det man gjør selv. For det må også til. Øvelse gjør mester.
Je revois la ville en fête croquant sous le soleil et sous la joie. Et j'entends dans la musique les cris, les rires qui éclatent et rebondissent autour de moi. Et perdu parmi ces gens qui me bousculent, étourdi, désemparé, je reste là. Quand soudain je me retourne, il se recule, et la foule vient me jeter entre ses bras.
Jag är filmstjärna akkurat nu. Ja.
You stopped a little bit early there because she said in the end, because a friend of her called when the camera was on, I'm a film star now, you know, I'm in this project, you know. You maybe not know about the project, and then the subtitle says, now you know. Who fell in love? Wonderful. The inspiration for me has come from this movement of rehabilitation, home rehabilitation and reablement, but mostly from Maureen Bissagnano. I heard her the first time saying it's all about moving from what's the matter to what matters to you, and it struck me, and it hit me in heart and head. This is the foundation of the work we're going to do. And I must admit, there is a personal thing in this for me, and that's my mom. She was growing dementia, and I was lucky enough to follow her up, living closely. I saw healthcare from a different distance when I started following my mom's story. And I saw something that I knew intellectually, but not emotionally, and that was when something really gets to you. And she had to go from one visit every morning, had a fall, went into a short stay, came back, and suddenly have 4 visits a day. She went with her dementia from meeting 3 or 4 persons a month to 30, 40 persons a month. So that gave a new dimension to our work with the pathways. You know, you have the big transmissions from hospital and back home, but when you're a patient, you have many more transmissions. And you meet 4 persons every day, and thus information flow so that they all present the same service, the health promoting service. That's a challenge. And we saw it's a mind shift. Robert showed the picture from yesterday with a mindset. So for me, this is a mind shift. I was trained to ask, what's the matter? To find the weakness and compensate in my education. But this is about the big question. Stay with my mom for a little bit. I told her about the work, and I said, tomorrow I'm going to speak to nurses about moving from asking the question, what's the matter, to what matters to you. And she took to her stomach and she said, oh, I can feel this here. And she said, the first you said, it made me feel small. But the second you said, that gave room for all of me. So this is the successful pilot that we build on. In Trondheim and Orkdal's region in Norway, they had a program developing pathways for elderly and long-term condition. This is a PhD from Tove Røstad, which has done great work with this, and our mentor, Anders Grimsmo, as well. So if you would like to go into this, please use the possibility to download our presentation and go to this work. We have 8 regional collaboratives in Norway, and that's about half Norway. And it's a model framing good practice, as you see from the successful pilot. And each collaborative is built on local ownership and the culture in each region for quality improvement. And it's not possible to build this without that connection. It's improvement teams from municipalities and hospital, and they meet in the learning collaboratives. But before they meet the first time, they get a list of preparation work they have to go through. And I think it's very important. Each and every team has to visit some patient that has been through readmissions to hospital. In the municipality, they do that. 5 patients. And they don't only interview the patients, but they go to the GP, to the hospital, both wards, the first admission and the second admission. They talk with their relatives, and they try to see the whole picture from the patient perspective. Sorry to say, folks, but I think we very often stay in our own perspective when we develop pathways. It's a service-oriented pathway, but this is a pathway that tries to address the challenge that each and every patient have to live through. So 4 times we meet, 2 days, over a period of 18 months, and we coach each team between the collaborative sessions. Here you see a pathway, a classic one, in hospital. You put primary care in the beginning and the end. Clinical pathways that you maybe think of when you think of our pathways have the aim of a better care coordination, and they deal with single diagnosis, and they are created on evidence-based guidelines. The problem with our patients, it's not one guideline. They need to be followed up by 4, maybe 5, maybe 6 guidelines because they have 6 different diagnoses. So it's multimorbidity, and it's challenged in a different way. So we can't stick only to the diagnosis. We have to look at the functioning level. And look at this picture, because this shows an image of a pathway. And when you see it, it looks like the patient is most in hospital. But they are not. They are living their lives in their homes. So we have structured pathway that really seek to find out how can we help the patients when they are at home. And this you can see here. These are our pathway from discharge from specialist healthcare to home care to the GP and to evaluation. And we put checklists on each stage of this. And this is borrowed from Trondheim, which started the whole thing together with the region of Orkdal. So we thought we have to make sure that this happens. So we made indicators, measure points to follow up to see, do we do this for each patient? So how does it look now? I'm not translated this, but the content of these measurements are about 4 issues. Prepare transition, which is very, very important. We see that patient satisfaction is very high in Norwegian hospitals, except on 2 areas: cooperation with the municipality and information and co-work with the patient before discharge. And the What Matters to You visit within 3 days, normally when patients come from hospital, the same day, but then start a conversation about what matters to you. It's not an interview, it's a dialogue about this subject. It's not asking 5 words and then getting the response. It's about building a relationship and be interested in something different than all the small symptoms, the details of a person's disease and weakness. Now this is about what really matters for Tordis. And then considered by GP within 2 weeks. Not everyone should go to GP, but we see that the GPs, they fall out of elderly's life above 80. It's a huge drop of visit at the GP. I wish I could work with Ulrika so that we could create a different reality on this. But we see that's a problem in Norway, a huge problem to have the GP active in patient's life again after 80. And then follow-up evaluation within 5 weeks, which is very important. We have to see, do we actually follow up on what matters to you? Do we do the things, the action that really improves on what matters to you? Very, very important. And of course that we can find early signs of changed condition. What then? So when conditions change, what do we do then? And then we stole shamelessly from Canada. We stole something they call PSFS, Patient-Specific Functioning Scale. We call it as you see in my button here, hva viktig for deg, skjema. What matters to you, Jim? We got lost in the letters, so we found what matters to you, Jim, as a better name. But it's the same. We measure from 0 to 10, how well do you function on what matters to you? So let's go back to Tordis a bit. What actually matters to her, my love? Put on the socks by myself, make my own breakfast, make my own coffee, and walk alone using my walker. You saw her present that in the movie. And you see, when they started this, they also asked her, well, how well do you function on those issues? And she said 0, 2, 3, and 3. And then they start training on what matters to Tordis. But those issues is the reason why she wants to stay at home. And why she maybe can't stay at home. Because she can't put on her socks. And you see, after 4 weeks training, the improvement. And when you switch the numbers and take the first one from the second one, you get an improvement. So if it's about 2 in improvement, like you see here, Tordis is not the only patient who have been met by what matters to you and follow up on this scheme. So here you can see an improvement of many patients from one unit in one of the municipalities participating in the collaborative. And here you see the measurement from colleagues of mine in the Norwegian Institute of Public Health. They measure patient satisfaction with hospitals. And you see the 2 lowest scores are on cooperation and discharge from hospital. And I think it probably is similar in other countries. This is old figures, so how are the new one? I took this because it's just the same in the latest measurements. So we decided that we had to work on what matters to you. Because early in the first collaborative, we saw that everyone responded well on the challenge. They went home from the collaborative, met their colleagues, the leaders, and they said, we are going to ask what matters to you. And what happened? It didn't happen. Some did, and they found it extremely difficult. A little bit uncomfortable, out of comfort zone, about like how I feel now. But they saw that this was very important, so they came back to the second collaborative gathering and said, this is difficult. So we decided to create What Matters to You Day. To have this one day, put on your button and go home. Last year, in 2017, we had 50,000 buttons. That's a huge number sent out in a small country like Norway. This is from 4th of June, 2014. A doctor were sitting in Tynset. She was on duty, and she had just put on her button, and she was sitting at the nursing institution for old people, acute ward. And in the door comes a farmer, 67 years old, and she immediately saw that, wow. He got a diagnosis of lung cancer in late autumn, so only half a year ago. And now she saw immediately, this is terminal. This is the end. And she saw the pain, she saw the weakness, how he needed to work on nutrition, how he needed to follow up on rest. The wife next to him looked very poor as well. So the first reaction till Åse Ingeborg Borgås was that, well, not to this patient. This is too serious. I need to stick with the old plan. I need to talk with him about pain, about resting, about last days of life. But some intuition gave her an alternative, so she said, no, this patient as well. And she excused herself a little bit and said, well, sorry, but we have this program we are a part of. And we try to meet every patient with this question. Actually, I would like to start our dialogue as well with this question. What matters to you? And this brave farmer, 67 years old, big guy, started crying. He really, with the whole body, cried. I bet his wife hadn't seen that many times. But after crying for a while, he stopped and he said, no one has asked me that question before. And then it came. I want one more night at our cabin, at our hut. The first time I heard that, I thought he meant a hut like a hut. But a farmer from that part of Norway, he does two things. He works in his fields or in a forest, or he eats and sleeps. That's three things actually, maybe four even. So what he said, I want to have time with my family. That was his message. So then magic happens. And the fascinating thing, all the things she would have followed up on, the pain, the rest, the nutrition, all that was taken care of. But the energy was to help him to the hut. He didn't come to the hut, but he didn't have to, because he told his wife and his kids, I want to have time with you before I die. So he was brought to the farm. It was a wonderful summer of 14. So he was sitting and watching his son working on the fields and in the wood, his wife around him, his daughter coming up with her kids, and they had time together because of this one question, what matters to you? I bet if she didn't ask that question, he would be 24 hours on this nursing institution to be close to his family. And I bet that the cost for the society would be much higher for the family not to discuss. So what they did was to let him stay in the nursing institution in nights and then bring him to his family. That was much more important for him than staying in a bed at a nursing institution in that kind of environment to finish life. So that's what we see. I like to lift up Jennifer Dorches because she heard the same as I heard from What Matters to You when Maureen talked about it for the first time, and she went immediately home to do the What Matters to You with Children's Hospital. And I would like to lift up my colleagues in Scotland, Sean Marr, who's not here, who is a colleague driving this global movement towards a change of healthcare that really contents this question, what matters to you? To good colleagues in Brazil, that's here, British Columbia, in Canada. Fritz is sitting here taking care of the Danish What Matters to You work. Hva viktig for deg? And my colleagues and friends in Trento, Italy, immediately saw that this is important, this is what we would like to get into. I love this. To see how it spread from the first collaborative in Norway in 2014, and to see how this develops to a global movement. But most of all, I love to see this, because when the end came to my mother, I was sitting next to her, holding her hand, and nurses comes in to give care to her, and they carried this button. They had a button on their uniform, but more importantly, they had the question, what matters to you, in their heart and in their head, and they showed her that they really, really wanted to see her as a whole person. And so it was for the last 6 days. Thank you.